هنقلب الجلسه كلينيكال، كل حاله 5 minutes وتتناقش with the panelist، وحضراتكم موجودين معانا. حاله من الحالات اللي بتشوفوها ادولهم دكتوره منى قداح، مدرس جهاز الهضمي والكبد واستشاري الحركيه بكليه طب القصر العيني. You have 5 minutes.
Good afternoon. Thanks, Dr. Muhammad, for your kind invitation. Dear Chairman, case number 1. We have a female patient, 53 years old, with worsening of symptoms over 2 years. She had progressive dysphagia, regurgitation, occasional non-cardiac chest pain. Upper endoscopy showed tachycardia. Barium swallow showed a picture of achalasia. ECRT score was 8. High resolution manometry was done. The catheter could not traverse the LES. However, there was absent contractility with pan-esophageal pressurization, as we can see, in almost 100% of these swallows. So the decision was, we have to look at the patient as a whole regarding the symptoms, upper endoscopy, barium swallow, and manometry. This is a typical case of type 2 achalasia.
Yes.
So the patient underwent POEM. 6 months later, the patient came for follow-up. She showed marked improvement in her symptoms. ECRT score actually dropped from 8 to 2. 3 or less, this is clinically significant improvement. Upper endoscopy showed incompetent cardia. High resolution manometry was redone. What was striking here that the patient actually regained contractility, not just isolated island, but swallows with a DCI contraction vigor more than 450. As we can see, 80% of the swallows were normal and just 20% were ineffective. So basically from 100% absent contractility to 80% normal, the patient was happy. We are happy. Everyone is happy. However, we face a problem. Okay.
What is the problem?
The problem
أكيد ما فيش حاجة تخلص على خير كده.
How to write the report?
Yes.
Chicago classification was not intended to deal with, it's only for treatment naive patients, not for, the patient was treated achalasia. So my question to the panelists, my dear professors, how to interpret and classify manometric findings, whether the IRP was high or not, and whether there's absent or isolated islands.
Could you please go to the motility?
Yes, sir.
Yes.
This is a failed poem. This is the failed poem. What you are seeing is where the guy cut make the hole. It's narrow, and there is a
مش هيعرف يجيب
continuation.
عليه يعمل عليه. Yes.
Pointer?
Yes.
Yes, it's supposed to be.
The up one.
You know, he cut it here,
Yeah.
and it's narrow, and everything accumulates here. This is why patients dysphagic. Just repair. This is the only thing you can do. Look at the barium swallow. You cannot see anything by endoscopy because endoscopy opens it by itself.
Yes. You mean the endoscopy opens. This is a failed
endoscopy,
poem.
If there is no such a bad stricture over there, endoscopy has no value. Barium swallow will show you some accumulation here, time barium swallow, but that's enough from my side. You see there is a water accumulation. This is not peristalsis. This is all about the accumulation. Just the patient needs repair.
So the next question is, this patient is, the ECRT score dropped to 2. So clinically, she's superb. She's coming for follow-up. She's fine. She does not have dysphagia. So would you consider doing...
That's a lovely patient for flip, but no one has it. But then just wait and see that.
Okay.
But repeat the endoscopy, look very carefully on that particular area and do a barium. Look whether there's an accumulation. If there's an accumulation, what the problem is, then repair. Otherwise, don't touch it.
She suffers from yours.
She's perfectly fine.
Keep it with you.
Okay, so the next and the last question: how to write the report? If this patient came for, I have to write the report. So if we assume that she regained contractility, or even in this case, how would you describe the contraction vigor? How would you comment on the LES in a patient who actually underwent POEM?
You know, I believe there is no IRP here because you couldn't pass into the stomach. Stomach sensor is all the way down, but you are showing all the way up.
Okay.
You are showing us the accumulation place. This is not LES where it's coming. You know, this is not LES. This is not just accumulation. LES is somewhere around here. It's not working. LES is up somewhere.
Okay. So how would you write it in the report? What would you describe?
I call it failed POEM. According to the other diagnostics, if patient agrees, repair.
So,
Comments?
if the patient is
Comment?
not symptomatic, we will just keep him on conservative.
You want to comment?
When
Mona-
I call it, this is short POEM. That should be performed a bit longer.
Thank you.
Comment.
So,
Mona, wait. Zahrona.
Thank you, Dr. Sirhat. I think this patient, he underwent the short bound rather than the long bound, just to cut the down, and the main IRB and symptom. If the card is scored, now he's improving, and the ERB, what is the ERB here?
the average was almost 10,
yeah.
but I cannot rely on ARP here.
Sorry, for the achalasia, we are not treating just only manometry. Just we see the clinical manometry and endoscopy.
Exactly.
And those patients, if just only short manometry, the RB is good and clinical is improving, sometimes you can see still some peristaltic. That one in type 2, you can preserve some peristalsis later on that you can see that peristalsis, but patient clinically improving and IRB is 5. I will not consider re-BOEM right now, just wait for time. And one of the complications issues, look careful that one blown out myotomy for sure for the long BOEM.
Okay. Thank you so much.
ثانك يو تو كونكلود هي يا دكتوره منى للجايز للشباب اللي مش يعني انترستد قوي في الموتيليتي يعني عندها حاله ايول
هو انا I think in here she did a short segment point and she should this is a type 2 achalasia she needs to do a long segment point so I think the problem was in the choice of the treatment. Yes, she is improved now for a while, but she will regain symptomatizing again very soon.
So conservative until proved otherwise, right?
Yes.
Okay.
Thank you Mona for this interesting case. الدكتور نجيب كونكلود الكيس. هي عملت بويم ومنى كانت عايزه تشوف هتكتب الريبورت ازاي، فبروفيسور سرهات قال ان هي اوريدي فيلد بويم وان التحسن اللي موجود ده في الحاله هو مجرد تحسن لحظي. برضو منى بتسال تاني هترايت ايه في الريبورت. هي تولد هير فيلد بويم. طبعا هي لو كتبت كده لحد من اللي عاملين البويم
مش هنكتب الكلام ده.
مش هبعت لها تاني. نيكست موف تو سكند كيس. سلمى عمران دايركتور اوف جي اي موتيليتي لاب ايكرد ليكتشر في انديميك ميديسن. She have also 5 minutes for case.
Good afternoon, everyone. I want to present this case of 20-year-old male presenting to our Center for Esophageal HRM.
Voice.
He
Please,
complaining
voice.
from daily dysphagia, regurgitation, chest pain, and weight loss. The symptoms has progressively worsened over the last 7 years following laparoscopic fundoplication. The current ECART score is 10 and no opioid use. He has past surgical history of laparoscopic fundoplication and hiatal hernia repair performed in the private sector in 2018 and history of preoperative dysphagia and heartburn and regurgitation. The estimated ECART score back then was 5. There is no available documentation of the preoperative EGD or the barium, and no preoperative HRM was requested before the maneuver. Post-operatively, he underwent 5 sessions of pneumatic balloon dilatation for spastic cardia. Each provided partial short-term relief followed by early recurrence of the symptoms. Our recent investigation in October 2025, the EGD revealed intact Nissen fundoplication wrap, and the omnipaque swallow showed segmental dilatation with tight tapering of the EGD, as seen here. And we did the HRM findings was 100% failed peristalsis, elevated RP, and pan-esophageal pressurization in 60% of the cases, and the rapid ring challenge and the cookie swallows also revealed elevated RP. So it's features of type 2 achalasia. So here the questions for the panel. Is the observed outflow here is a pre-existing condition, we cannot tell, or it's a post-fundoplication complication, and if there is any specific manometric parameters that can help differentiate primary versus secondary achalasia. So,
To conclude,
I believe the pattern, if you have a fundoplication, if it weren't for a dysphagia, you can find, if you have provocative maneuvers after a fundoplication, you might have an obstructive pattern on rapid ring challenge if the lap is good. There is no, the big issue, there is no peristalsis. So this is what's, As for your second question, no, I don't believe, and correct me, Sarat, if I'm wrong, they cannot distinguish on a manometry profile the primary or the secondary.
The same cutoffs we
You
can
have the same pattern. It's like alcoholic liver disease and fatty liver disease. If you don't know he's alcoholic, it has the same histological picture, no? So these are my answers. Sarat, any comment?
This is the best example why before the anti-reflux surgery, a high-resolution manometry
essential.
must be done, not should be done. Possibly because of the symptoms, the patient had achalasia before the surgery. Now they put a wrap on top of achalasia
worsened the
and
symptoms.
cooked. We have such patients as well. What we do, I have a very skillful PAM guy. I send the patient to the PAM. And because reoperation is pretty difficult by the surgeons. Either you reoperate the patients, just open the whole wrap and perform a Heller and perform a door from the application on top of it, or directly go with a PAM. I know what you guys
So
think
a
about.
poem is a must here, not only a
But
wrap.
if I may, just to illustrate what Sarat says, it brings to my mind a quote. The surgeon assumes that he has heartburn, he has regurgitation, and the
Yeah.
dysphagia due to the heartburn. And there's an old saying that says, "Don't assume, because when you assume, you make
You
an
make
ass out of you
again,
and me." So he
yes.
make an ass out of him and the patient. So
Yes.
this is why you should do a preoperative manometry.
Yes. Let me conclude. When you show it first time, your case,
This
this
is the
case
first slide?
for Salma.
Yeah, but it's worsened. It's worsened after the fundoplication. It was occasional before. It's
Okay,
might
let's
be-
be
Just,
conclude.
I have a comment.
Conclude and ask you. Okay.
طبعا pre-operatively for the anti-reflux measurement, either to go with the high resolution manometry or timed barium. Because high resolution manometry is not available all the center, and you will not keep the patient symptomatic for the gait for a long period. If you do the timed barium, that you can measure the remnant of the contrast in the esophagus in 2 and 5 minutes. If that one concludes that there is obstruction, so need this patient further investigation to rule out the achalasia, or it could be with the IV. But the high resolution is not available anywhere. Just do the timed barium that will give you clue before go with the anti-reflux.
طيب for sake of the time, because we have two cases also. الحاله بتاعت الدكتوره سلمى هي حاله كومن بتحصل كل يوم، انه عيان عنده هيتس هرنيا وهي جايه لها اصلا بديسفيجيا. العيان عنده هيتس هرنيا او العيان عندها هيتس هرنيا واتشخصت هيتس هرنيا، بقى متشخصه صح ولا لا؟ راحت للجراح بعد المنظار وما تقاسش الافيكاسي بتاعت الموتيليتي باترن بتاعها، فجت لدكتوره سلمى تاني كومبليننج اوف ديسفيجيا. والمسج هنا انك مش هينفع دلوقتي في ال 2025 انك تمد ايدك على عيان انتي ريفلكس سيرجري، سواء بقى هو يعمل هيتس هيرنيا فاندوبلايكيشن او ايفن انتي ريفلكس سيرجري وزاوت انك تعمل هاي ريزولوشن مانومتري. This is key message, you can take it. Thank you. شكرا جدا يا دكتوره سلمى. Thank you very much. المسج الاولانيه كانت بحاله الدكتوره منى، كانت عن فيلد بويم ونراجعها ازاي. المسج الثانيه كانت على حالات الهيتس هيرنيا، وقبل النيسن فاندوبلايكيشن لازم نعمل لها مانومتر. انا بشوف الحالات زيكم على فكره. Now for ريهام عدلي, lecturer of hepatology gastroenterology, Mansoura University. You have 2 minutes because Asra Yani is more.
My case is female patient, 36 years old, with no past medical history, complaining of non-cardiac chest pain, dysphagia, and weight loss for the past 4 months. Upper GI endoscopy was performed outside our unit, showing dilated esophagus with retained food and saliva, passage of the scoop with difficulty, picture suggestive of achalasia. Barium swallow was done, again dilated esophagus with delayed passage of the barium, narrow smooth tapered lower end consistent with achalasia. This is her barium. The patient was referred to our center for high resolution manometry, which was done. This is her traces. Do you need to comment? Yes.
Have you done provocation test?
Yes. Failed response to provocative test. We had normal contraction pattern and vigor in 60% of our swallows. failed contraction pattern, and 30% of all swallows, and weak swallows in 10%. Failed deglutitive inhibition test. IRB was upper limit of normal. It was about 22. And evidence of secondary pressurization during the swallows, especially in the supine position. No hiatus hernia was encountered. Failed response to propagative test.
What does it mean? Failed response. What is the meaning?
There was
She
normal
means
or
she
pathology?
means she tried.
Yes, I
She
did.
tried, but I think she writes it wrong. She tried to do propagative test and
yeah,
the
the
same
patient could not
responses.
tolerate.
Patient?
The patient could not tolerate the cocky swallow or the multi-bravo
She
swallow
cannot.
test.
She tried to do propagative test.
Yes.
She vomited?
She vomited.
She vomits, yes, and she had the sense of a lump in her chest during the test.
How long she has been suffering? How
4
many
months with weight loss.
years? 2 months?
4.
4 months only?
Yes.
I'd rather to go all the diagnostics, endoscopic ultrasound, CT and everything.
We
Because
had a
that's-
case like this back in Turkey in your lab. Remember? So, back to Chicago 4 classification, the patient would had the picture of esophageal-gastric junction outflow obstruction. So the patient was referred to the surgeon with her report, but the surgeon was not convinced and went for a laparoscopic hilar myotomy. However, the surgeon found multiple lymph nodes along the greater curvature of the stomach together with the thickening of the cardia. I've managed to get the video of the laparoscopic assessment. This is hair laparoscopy. I know you are not surgeons, but I got hair videos. This is video number 1.
Without endoscopic ultrasound, without CT, the surgeon directly operated.
Yeah, he said he was convinced that this was type 2 achalasia, not
Because he was very clever.
He assumed.
Yes.
Yes,
Yes.
there is a peristalsis.
no. He was convinced. Again. Later, he omitted the operation and closed the patient and performed another upper GI endoscopy, which revealed nothing apart from multiple ulcerations in the stomach. Biopsies were taken, only revealed mild superficial gastritis. What do you recommend to do our next step? Dr. Fadi?
He was here.
He should have taken biopsies because there are nodularities. Yani.
This was
double
the second-
jeopardy. He saw abnormalities and he had in front of his eyes should have taken biopsies. And
This
here you
was
do-
his second mistake. When I asked him, did you take biopsy from
He
this
was-
mass? He said, no. I closed the patient and sent her home.
Endoscopic ultrasound and CT. I
ايوه
could
بس
say.
زي ما قال دكتور نجيب.
So, we have done endoscopic ultrasound, endoscopic biopsies from the gastric wall, endoscopic ultrasound biopsy from the perigastric mass close to the pancreatic body. Unfortunately, the patient was diagnosed as having infiltration by signature
My
carcinoma.
case. I have a case like this. Me and Reem. We have this is. I have a case like this from ASU. To conclude, ده واحد من الانديكيشن اللي بيخليك يعني تمشي ورا الموتيليتي لاب. هو مش بس بيحمي عيانك لكن ممكن يشخص لك. فالعيانه دي ماشيه في سكه
أنا شفت حالة زي دي كده عند بروفيسور
ديسفيجيا.
سرهاد برضو.
المفروض
نفس
تعمل
الحالة.
بويم Yes.
if I may في هون element كتير مهم بالهيستوري.
Yes.
You have weight loss يعني في نقص بالوزن خلال 4 أشهر. Usually achalasia شو عشان هذا سأله بروفيسور بور قد ايه لها بتشكي.
Yes.
شو have a 4 month dysphagia with severe weight loss. So this also should
So-
really ring for a secondary cause of achalasia. This
So-
is a by the book thing. This
so
is simple
Fadi-
clinical
so Fadi-
upfront. This is why Sirat asked
Yes,
the question,
yes.
how long did she
Yes.
been done?
سو فادي زي ما قلنا مش كل حالة ديسفيجيا هي حالة أكاليزيا أنها الجديد
Pseudoachalasia due to
Yes.
malignancy.
مش كل حالة ديسفيجيا هي حالة أكاليزيا. ناخد بالنا وما نركبش الحالات حتى واحنا بنشتغل في الموتيليتي ما نركبش الحالات على الدايجنوزس جو فورورد. حالة طلعت تخيل بقى ان هي طلعت سودو أكاليزيا تو مالجنسي ولو كانت اتشقت بويم الموضوع برضو تاني كان هيبقى مش احسن حاجه. ثانك يو ريهام شكرا جزيلا. لاست كيس فور ريم عزت اسيوط يونيفرسيتي. اتكلمنا على حاجه تانية. احنا دلوقتي كان عندنا حاله بعد الجراحه بعد عمل هيتس هرنيا دخلت في ديسفيجيا وعندنا حاله بتاعه ريهام كانت متشخصه اكاليزيا طلعت تيومر. عندنا حاله بقى الاخيره
last case إن شاء الله.
بتاعه ريم عزت.
A 54 years old female that is known to be diabetic, obese, BMI 40, history of repeat choking and reflux, sense of fullness all time. She was advised by somebody that she should lose weight because this is the cause of her choking and reflux, and bariatric surgery was done. It was no upper endoscopy or manometric studies before, as usual, the common mistake. Post-operatively, the patient began to complain from nausea, then vomiting that turned to be persistent vomiting and not responding to any medication for a whole year. Once again, she sought medical advice and upper endoscopy was done, showing residual food on the esophagus and hiatus hernia in the cardia with elongated stomach as she had sleeve operation. And gastroparesis was considered. Upper endoscopy didn't show anything biopsy-wise. What would you suggest for this case? CT with oral study or manometry? What would
CT
you
or
suggest?
study or manometry. She's post-sleeve
Post-sleeve
dysphagia.
dysphagia with
Barium?
Post-sleeve dysphagia.
Post-sleeve.
No, I know anything about the barium swallow.
About what?
Barium.
Barium swallow.
No, she didn't.
Barium is good in
So,
order to show the
she didn't
active.
do-
There,
Function.
sometimes in very centers in Egypt, and I mean my colleagues, no barium by the high quality is found. It's replaced by gastrographene. So like
No,
in Reem,
but-
I'm looking at the fact, the fact.
Yeah.
What's happened, not what.
Yeah, no time. They
except-
didn't study at my place.
So they replaced it with CT with oral contrast. And I think that as the Zahranital, it's the timeline barium or just barium swallowed is the fact. So she asked it, what the next step? To do CT with oral or esophageal
Could
manometry?
you go back to the endoscopy, please?
Yes.
There was retained food in the esophagus, and the endoscopist said that she had GERD lost English classification A. The cardia is incompetent, health type 3, with elongated stomach due to sleep.
العيانه دي تعمل سي تي with contrast ولا باريوم ولا تعمل موتيليتي؟ العيانه دي عملت سليف، خست، بعديها جايه بسيمتومز اوف ديسفيجيا والاندوسكوب في accumulation اوف فود. تعمل سنتيجرافي سي تي with oral contrast. دكتور ماهر، دكتور نجيب، سنتيجرافي، دكتور هدي، الاثنين سي تي with manometry. Yes.
And those patients post-sleep, usually it may affect post-sleep on the IRB, and you can increase that 1 minute to the achalasia one. It is one of the hard, I think, topic talking about
Yes.
achalasia
Let's go because
Okay, she refused to do the CT with oral study, and the surgeon refused, and we did esophageal
she
manometry.
refused totally to do CT.
Yeah.
Yes.
And she turned it to be achalasia when we did for her according to Chicago classification. Lower esophageal sphincter was hypertensive, high RRP, contraction pattern 100% non-peristalsis integrity 100% failed, and she was type 2 achalasia after sleep.
Well, the main complaint was vomiting, right?
Yes, persistent
The
vomiting.
vomiting coming from the stomach or from the esophagus?
What?
Vomiting is coming from the stomach or the esophagus?
تعالي
Now,
esophagus.
it's easy to ask the patient what type of vomiting you have.
Esophagus.
That the undigested food is coming. Then there is the dysphagia.
No,
No.
She's not educated to that. She's saying
No,
I'm vomiting
sometimes
all
they
the time.
confuse
Yes.
between vomiting and
And
dysphagia.
retained food, that she's vomiting retained food. She's saying I'm vomiting everything, even water.
important here because patients lost the fat in the abdomen, and this is possibility of severe mesenteric artery syndrome in this case. So, is patient severe mesenteric artery syndrome must be excluded.
No,
from the patient.
the case اللي حصل للعيانه حصل بعد السليب جاستروستومي. هو السؤال my question to the panelists and the floor. هل هناك incidence if there is the incidence for post bariatric surgery achalasia؟ هل هذه المريضه كانت evolving achalasia؟ هل كانت it was evolving achalasia and the surgery would input to do the achalasia it before bariatric surgery if this patient was already achalazic or early achalazic and the bariatric surgery evolved this achalasia, yes or no?
هي في ستاديز وقتها كانت الموضه
I saw
ايام اللاب باند اتس بسودو اكاليجيا سيرجري يعني we have multiple studies multiple reports of pseudoachalasia after lap band. For the sleeve, it's a refluxogenic. So the problem is that there is no operative header.
Okay.
So you cannot answer the question if it was a pre-existing. But to my knowledge, there is no publication showing that in achalasia developing after sleeve, provided you have excluded the achalasia before operative. Correct me if I'm wrong.
I saw. The second question for you. It is a mandatory for like anti-reflux surgery. It is a mandatory for sleeve gastrostomy or bariatric surgery to do manometry before? Yes or not?
No.
No.
According to the symptoms, of course. If there is no
Just upper
symptom,
GI
no
theaters.
dysphagia, no motility.
According also to the bariatric recommendation of bariatric surgeons, it's not mandatory. You don't see it in their guidelines. Yani.
Yes.
This is.
But at least you do endoscopy, and if you
At
found
least
anything in
endoscopy.
Yeah,
endoscopy, you
that's
would
a big
recommend
mistake,
manometry.
of course.
Yes.
Yes.
Thank you,
What would
Reem.
you recommend for
Yes.
this patient in this case, if she's achalazic after sleep?
I'm not sure about that.
She wants to repeat.
Yeah, maybe.
This patient is developed achalasia post the sleeve. It can happen. I have to see many patients in Saudi Arabia.
I see it.
Yeah, that can. Just treat him like achalasia patient. You can do that
Okay,
one.
she had
That's-
point
What?
1 month ago.
She choose
Yeah.
your right, your
Oh,
way.
yeah, she
She
had
choose
point
your
1
right.
month ago, and she's now free of symptoms. Or 1.5 months.
دي حالة البارياتريك سيرجري اللي قدمتها دكتورة ريما عزت، اللي العيان بتاعها عمل سليف جاستروبلاستي، وبعد السليف جاستروبلاستي عانت المريضة من أعراض اسفيجيا والريتين فود. فاحنا كنا بنسأل السؤال الأخير: هل هذه المريضة جاي لك، هل هناك مرضى كانوا هيتحولوا إلى أكاليزيك بيشنت ومع إجراء الجراحة حصل سرهات أنفادي عند خان؟ الثلاثة قالوا لا، احنا ما قريناش في الريبورتس، او ممكن محتاجين نقرا عشان نسأل هل زي ما قلنا قبل جراحات فتق الحجاب الحاجز محتاجين نعمل مانومتري للعيان؟ طب برضه قبل العيانين اللي بيعملوا عمليات تخسيس هل محتاجين نعمل لهم مانومتري؟ الوحيد اللي وافق يمكن دكتور زهراني، او قال انه شاف حالات زي كده كتير نقدر يعني نشوف ومانج از اكاليزيك
بس
بيشنت.
احنا دورنا في الليتريتشر بعدها
ودورنا في الليتريتشر ولقيناها. انا ممكن اخد 1 كومنت صغير وهسال سؤالين علشان الجوائز بتاعت الموتيليتي، فهجهز سؤالين. How many types of achalasia? لا مش عايز تفاصيل، هم 3 تايبس. مبروك، ده مش السؤال. السؤال الثاني بقى مهم، مش ده السؤال خالص. السؤال بيقول: هل يفرق تايبس في الاكاليزيا في المانجمنت لما تبعتيهم للجراح او لبتاع البويم ولا لا؟
على حسب فتحه البويم هيفتح عند كام سنتي؟
ايوه
اللونج والشورت.
حلو، قول بقى.
تايب 2 بيبقى
تايب 1 و 2
10 سنتي.
يعني الفكره وصلت وجاوب. عايز اجابه. تايب 1 و 2 10 سم. هو كده صح؟ طب هو الدكتور عرفها صح، بس انا هكمل السؤال. تايب 1 و 2 شورت بويم، وتايب 3 لونج بويم. تايب 1 و 2 هيفرق قوي في الدايجنوزس، انه اللي هيقطع السفنكتر. I'm right فادي؟ I'm right. شورت بويم and تايب 3 لونج بويم. اول جايزه دهب معانا بقى. تعالى هنا كمان، استنانا.
كم جرام؟
استنى بقى لغايه لما نسلم مره واحده كده مع بعض. السؤال الثاني سؤال برضو سهل.
كم جرام الذهب؟
كم جرام الذهب؟ لا، ما هو يقول بقى. السؤال اللي بعديه سعر الذهب قبل ولا بعد؟ السؤال اللي سأل تاني في الموتيليتي ستادي: هل اقدر اعمل لعيان موتيليتي على طول من غير ما اعمل مناظير او باريوم؟ يعني لو شاكك في عيان اقدر اعمل له موتيليتي، اقدر اعمل موتيليتي ستادي قبل ما اعمل مناظير او باريوم؟ ولا لا؟ لا نبيله لا. حد تاني؟ حد عايز ياخد ذهب؟ قول يا دكتور لورا، تعال اتفضل. ليه لا؟ ولا لا وليه؟
لان في بعض الحالات اللي هي بنعمل لها upper GI endoscopy بتبقى نورمال، فبحتاج ان انا اعمل المانومتر.
يعني لازم نعمل منظار.
لازم انا اعمل منظار.
هو ده مش السؤال، ماشي؟ السؤال بقى بيقول هل المانومتري بيشخص ريفلكس ولا لا؟
بيشخص طبعا.
رونج انسر. هل المانومتري بيشخص ريفلكس ولا لا؟ احيانا الدمانومتري دايجنوز جيرد. نو. ادى اندوسكوبي دايجنوز جيرد.
adjunctive يعني مساعد.
ادى بي اتش دايجنوز جيرد.
gold standard.
نو ستاندرد. جولد ستاندرد.
ذهب.
اختار 3 حاجات دايجنوز الجيرد: اندوسكوبي، مانومتري، بي اتش. تعالى بقى، يلا اديله جايزه. شكرا جزيلا. 2 جايزتين ذهب من شركه بورج. تعالى اتفضل يا دكتور عرفه، اتفضلوا. باناليست بقى اتفضلوا سلموهم.